Okay, we're back. So let's jump right into phase two. Again, this is a good phase to go into right after lunch because it's familiar. It's talking about the patient during the office visit, so things you're familiar with. So we'll just go over this pretty quickly, but highlight a few things on requirements and processes. Again, this is me. I have no disclosure directly related to this presentation. So during this phase, when the patient has now come in for the office visit, we'll look at checking in. You check the insurance, copays, confirm addresses, review of symptoms, and things like that. The only thing to point out here is if you have any pre-visit questionnaire you want them to fill out, this is somewhere you want to put that in there. Rooming the patient, calling room the patient, and then pre-consult, checking vitals, medication reconciliation if the person has a recent ED visit, behavioral health screening if that's due, AWVs, we'll talk about that as well. And then we go into consultation with the provider where they would examine, discuss additional tests, and then post-consult patient education, so make sure they understand next steps, medication orders, non-medication orders, and check out and preparing for the next patient. So as you can see here, some of the requirements we'll be touching on include medication reconciliation, which is for function 2, behavioral health screening, function 3, risk stratification, we talked about that again. We come to see here that in that consult with or encounter with the provider is yet another opportunity for his clinical intuition to kick in and see if they need to adjust the level of the patient. And then you know that one of the ECQMs is for diabetes and hypertension control. So if it's a diabetic patient, you want to see if the patient is due for the A1C test. Also, if they're hypertensive, you want to see if they have had their 3-monthly or 6-monthly kidney profile done. And then for patients who are also diabetic, you want to see if they have nutritional needs that need to be addressed, and or physical activity and exercise, discuss what that looks like. Again, this is taught under medication management only because we want to, again, keep emphasizing that it's not only about prescriptions, there's more that goes into the total treatment modalities for your patients. And then post-consult. Again, so the session objectives here, again, just like with phase 1, is to go through workflow, people, process, technology, the care team roles. We'll discuss AWVs and EMR, other screening tools, and data necessary for warm handoffs, documentation and documentation best practices now during the office visit. So please take a moment in your pre-post survey forms, complete this survey for topics 13 through 17. I'll give you a few seconds for that. Okay, so again, reminding us of our test patient, Miss Alexa is wiggling there. So be mindful of her clinical profile. We talked about, just before we ended phase 1, we talked about key things to bring up during the team huddle about this patient, the fact that she had a recent hospitalization, the fact that she's diabetic hypertensive, and what other care gaps we might need to close. So that said, during check-in, you want to verify insurance updates, contact information, accept copays, any consents. But again, I just want to draw your attention that if you have any pre-visit questionnaires like the AWV forms, this is when you can administer those. And the experience here is, that is captured here, is that she feels comfortable coming for this visit because she loves her care team, hopefully, and she did not need to verify her identification with others in the waiting room close enough to hear her reply or respond. You know, many times you go to the front desk, so what's your date of birth? I'm like, really? Why would you want me to say that? So I know that it's just routine, but I think it's not right that I sit down in the lobby and I hear everybody's date of birth. So they have to figure out a better way to confirm that. You can have a sticky note and write this, can you confirm that it's a date of birth with a nod, yes or no, something like that, or a lower tone, or figure it out. But that's something that I think I've seen some practice take the time to kind of change, but some practice still just do it and not think about it in real time. Okay, so step 2, rooming the patient. So room is prepped to receive the patient. Patient physically is ushered into the room. Notify the PCP when the patient is ready. Considerations here for patient satisfaction is that the wait time, patient's not waiting out there for too long. And then the exam room is clean. So the experience captured here would be that she's happy to have a short wait time. I showed up and I was called back soon enough. And when I got into the exam room, it's very clean. Again, I say this to say that most of what we're discussing here, 60%, if not more, you already do. I just want you to keep remembering or reminding yourself that even though you do these things routinely, it does have a positive impact. I'm one person who's a stickler for cleanliness. So when I walk into the exam room and it's clean, I'm smiling. Now I may have a longer wait time, but at least I'm in a clean environment. So again, something to think about. So step C in phase 2 is the pre-consult, where the MA is checking vitals or the nurse reviewing symptoms and things like that. So her vitals are checked and medication reconciliation is done. Again, remember that this is a requirement. And the results today for Ms. Anexa shows that her BP is 140/90. Her weight is 196 pounds. Her height is 5'5". So again, looking at this, we'll discuss this further. You was like, oh, your BMI is kind of sorta, but she probably just lost 5 pounds. So while the BMI may not be what you want it to be, you have to celebrate the incremental steps she's making, right? So again, always look at the holistic view or the full picture of the patient and be encouraging as you can. And we'll talk more about motivational interviewing in session 11. So ways that you can really improve that relationship with the patient by walking her through her results. As part of her prep, behavioral health screening is done since she is due to have one. PHQ-209 is administered, and this touches on function 3. She's also due for an AWV, and the MA will finalize it shortly after the doctor's consult. So even though the pre-questionnaire was given at the time of check-in, the MA will follow up with the patient after seeing the doctor to do the AWV. Now, her experience shows that she's happy to know what her vitals are today after being concerned for the past 2 days, right? And she lost 5 pounds since her last visit. So with rooming, again, looking at these key points, checking the vitals, review of symptoms, patient health concerns, is there any care gaps to close? VPAs and EMR alerts, it's going to vary depending on what EMR you're using. But if you already have it set up that you want alerts in case something is due, when you pull up the patient, you see it will flag red, that something is due, and AWV is due, BHI is due, or to order another A1C test. So again, if this is not working for you now, this is what you can do. So again, another practical example. People have, I guess, they shy away from reaching out to the IT team and telling them exactly what they need. It's been very difficult because they always see that from a business perspective. So for every feature or capability you ask for, another $1,000. Or you need that, well, I can give you this towards blue, not too purple. If you need all the way purple, another $1,000. So it's very frustrating. So they almost avoid calling the IT altogether, the IT vendor altogether. So this is, if you do have a CTO, please work with them, because part of the benefits you can get is to have someone on their team who understands the IT speaks, or data analyst who understands how to use the IT system to mine data and analyze data. They are comfortable, so they understand what they're saying. If you have a practice and you do not have a CTO, I would encourage you to have at least a data analyst on your payroll, somebody who can meet with the vendor. And if I'm using your EMR, the least you can do is allow me to have a bi-monthly meeting with you. We need to know what, because things get updated all the time. We all have cell phones. I close my, wake up in the morning and I'm like, what happened? It's another reboot. So that's the same thing for all the IT solutions we have. So you need to have that ongoing conversation so you know when things need to be updated and things like that. So here is an example of when you room the patient. Sometimes you have, again, back to the care alerts we're talking about, or EMR alerts you can have. Sometimes when you have the patient room, they can just have the patient flagged in the EMR that this patient is ready to see the physician, and you also have the physical notification by pulling up the tab outside the door as well. This is a screenshot from Epic. I'm comfortable using Epic for the most part. For some of you who do, you can associate with this particular slide. So what I like about this, and this is similar for most EMRs as well, probably slightly different configuration, but you have a summary of the patient here, the patient's name, date of birth, whatever, and then who is on the care team. So right now here, it only shows that it's Dr. Links, but it'd be nice to also see who the care manager is and things like that. It gives you a summary of the office visit and what the patient's vitals are. And if you want to click on here to see last 3 years, how many internal medicine visits, lab, imaging, other. So it gives you a snapshot. And then this tab is for the rooming, and you can see the different tabs. So the MA walks through this. And why I like this is that it gives, you don't have to think about it. You just know you have to, this helps you as a reminder, prompts you to get stuff done and check the boxes. So visit info, vital signs, allergies, verifying treatment benefits, medication review questionnaires if you have any in there, answers, patient history goals, screening, and MyChart proxy. So this one here is an expansion of the medication review tab. And as you can see, you asking the patient, again, doing the medication reconciliation, not taking, so that you can actually hit refresh, and then it will take off any medication that the patient is no longer taking. So step B, now the patient has been prepped and roomed, and the physician goes in to see the patient. The focus of the physician here or the provider is medication management. Again, this is something that no other person on the care team can do. So this is something that they need to focus on. Now, I will say we should know that the difference between medication reconciliation and medication management, right? Back at least as of 2 years ago, I know that medication reconciliation is reserved for somebody with a clinical certification. So things are changing, so we never know. You just need to probably be trained in it, and then you can do it, and then somebody who has a clinical certification can review and approve. But I know that medication reconciliation is kind of delineated for the clinical nurses, but medication management is for the providers. So again, knowing the difference. So here is also touching on function 3. Also in the examination and reviews with the patient, Dr. Links can apply his clinical judgment to adjust risk level. Again, another requirement comes up here, which is risk stratification. Additional tests should also be ordered for Mucinex for A1C and kidney profile, ECQM is touched here. So again, I want you to keep remembering that as you walk through the natural flow of your day, you are checking those boxes on those requirements. So when you pull those requirements, again, they should not look overwhelming, inundating. You should just know how it overlays with what you do and make it work for you. Her experience here is that she's happy with her meds being called in, and additional tests will be done to further explore if she has any other issues. So during the consult, things to think about is a warm handoff. We want to watch we will watch a short video clip on warm handoff, so you get to see how that's done. Review of pre-consult assessments, examination, confirm pre-visit risk stratification tier with clinical judgment, discuss additional tests, close care gaps, discuss medication management, and address the patient's health concerns. Now, this is one example where we will play the video where I want you to take note. This is something that I know some practices do, maybe 20% or less. But if you're thinking about team-based care, this is where we need to go. So I would recap at the end of the video, but I want you to watch.
Engaging patients and their families can improve patient safety in the primary care environment. One way to do this is through the use of a warm handoff. A warm handoff is a handoff conducted in person between two members of the healthcare team in front of the patient and family or caregiver. A warm handoff is similar in concept to nurse bedside shift report and engages the patient as a member of the team so that he or she can speak up, ask questions, and clarify information.
Hey, John, how you doing?
I'm doing all right, Doc.
Mr. Winston is now a proud grandpa.
Oh, that's right. How's your son's family doing? I bet it's exciting having a new grandbaby in the family.
Oh, yeah, it is. They're doing great. Thanks for asking. By the way, this is my daughter, Sue. She helps me with my medical stuff.
Welcome, Sue. Nice to meet you. So, let's have your report, Amelia.
Well, Mr. Winston said he experienced an episode of a rapid heartbeat while he was working at home 2 nights ago. When his heartbeat wouldn't slow down, he went to the emergency room and they kept him overnight for additional testing and observation. They diagnosed him with atrial fibrillation and prescribed Xarelto, 10 milligrams to prevent stroke. There's no history of AFib in his charts. His pulse is 52 and his blood pressure today is 135/80, and he's lost 5 pounds since he was last here 2 months ago. He's still taking his Lipitor for his cholesterol.
Rapid heartbeat. And this never happened to you before?
Well, it has. I just didn't tell anyone about it.
Dad, why didn't you tell me?
Well, it was such a small thing, I didn't want to worry you about it. And it stopped on its own, so I thought everything was okay.
I want to hear what happened both times. Let's start with what happened 2 nights ago.
Okay, so a couple nights ago, I got home from work.
Warm handoffs improve communication, encourage engagement and questions from patients and caregivers, allow patients to clarify or correct information, build relationships, provide a safety check. As you'll see next, even a passing comment can lead to the identification of safety risks.
Amelia, do you have any information from the hospital?
I got the hospital to fax over the discharge summary, and Mr. Winston brought his discharge instructions in with him.
Oh, that's great.
Mr. Winston was seen by Dr. Ortiz, the attending cardiologist, at 10:15 on Tuesday nights. After Mr. Winston was diagnosed with atrial fibrillation, he was prescribed Xarelto, 10 milligrams once a day, which Mr. Winston says he's filled today and has started taking.
That makes sense, but I was told 3 times a day, not once a day.
May I see the discharge summary, please? The blood thinner Dr. Ortiz prescribes is only taken once a day. The instructions from the cardiologist says you need blood work in 3 months. Maybe that's where things got mixed up. You take 1 pill once a day with your evening meal, and in 3 months you come back in for blood work, and we'll see how things are going.
That makes sense, but this thing is kind of confusing.
Just to be safe, I want to make sure we're all on the same page. Can you tell me how you're supposed to take these pills?
I take one of these pills, Xarelto, once a day at dinner time.
Yes.
Can you take it in the morning at breakfast?
No, this should be taken in the evening, and it's important to take it with food. Okay, now let's take a look at you. Thank you, Amelia.
It's so nice seeing you both.
The warm handoff is a tool that primary care practices can use to better engage patients and families and to improve communication. This can lead to safer care, better patient understanding, and greater patient satisfaction.
Okay. So while you may have thought that that clip you saw is impractical, right? Everyone's busy, so the MA cannot sit there to kind of do the warm handoff. And yeah, that's the vision. It does happen. There are practices who currently do this. I have a couple of colleagues of mine who have not typed a patient note in 10 years. They know how to type, they just don't, because they've figured out how to leverage team-based care. So the MA is equipped and they kind of balance it out to have more MAs. So I think MA to provider ratio is about 2 to 1. So what they do is that they get the patient, prep the patient, and they stay with the patient and scribe while the physician focuses on consulting with the patient. Now, because the patient already has been seen by that MA, they already feel familiar. They just took your vitals. They just asked you questions. So it feels like it's continuing. It's just a continuation. And then, you know, the warm handoff can happen there as well, but it goes beyond that. They can take the notes and wrap it up and say, okay, see you later. And the patient feels like, oh, he's giving me all the attention I need. He's not typing. And as great as it is that my colleagues do this, I have yet to have a personal provider who has taken care of me in the past decade do that. They've always been in front of their computer. So sometimes they'll be cordial and they'll kind of just talk to me more. And I know they're going to go like stay 2 hours after work to do your paperwork. So again, but it's doable. Some folks think this is impractical, early 2, early 3, but think about it. Think about how you can adjust, because the physician will spend less time because you're supporting him well enough to do so, or her enough to do so, or the PA or the MP. So think about how you can begin to transform and adjust, but it's feasible, it's possible, but there's no way to transform your care delivery doing things the way you currently do them now. So annual wellness visits. So this is important because this is how you get the attribution list, right? And some practices said, well, I only got 40%, 50% of my patients. I should have had more. I know that some of that was error on the part of CMS maybe. And sometimes data just have errors in them. Hopefully you would see an adjustment come program year 2. But also the AWVs are one of the criteria that is used to assign or attribute patients to practices. And just also to put that in here is also by the plurality of eligible primary care visits. So who has the patient seen the most in the past 24 months? So it's a combination thereof of those things that CMS looks at to actually attribute the patient to your practice. Now, some physicians or practices stay on top of AWVs. However, you also have, I think, some organization who goes out there and just do a random AWV and get paid for it, can get reimbursed for it. So there's no workaround just yet for those. The hope is that if you know your patients well enough, they would not, be, subscribing to a random provider just because, and you can inform them about it. If anybody comes to you asking for this, say, never mind, my provider will take care of that. And then in your EMR system, make sure you have those alerts that inform you, hey, these group of patients have an AWV due next month. So you can reach them ahead of time to remind them to come in for the AWVs. So the CPT codes for this are 0438 and 0439 for initial and subsequent visits, so you can bill correctly. And the services provided during AWV are different from the typical preventive care visit or the Welcome to Medicare visit. So please be aware. Now, who can actually furnish and bill for AWV? It's a big question. And again, back to the balancing act of resources and what they do. It could be a physician, it could be a physician assistant, a nurse practitioner, clinical nurse specialist, or a medical professional, including a health educator, registered dietitian, nutritional professional, and by the time I got here, I say anybody, right? Or a team of medical professionals working under the direct supervision of the physician. So you have a lot of MAs who do AWVs now, and the provider just reviews and sign off on it. So how many of you in your practices have only the providers doing the AWVs? So at least your takeaway from here is that they can do it differently. They don't have to do it. They need to supervise and review it, but they can have the MA actually do the AWV and spend more time with the patient. I will also say that if you want to implement AWV in your practice, making sure that you want to stay on top of it. If I have, for example, 1,000 patients, I want to make sure I do complete the AWV for all 1,000 patients. Step one is I have to establish a program plan and identify who are the patients that are eligible, monthly, quarterly, whatever, and do an outreach and engagement. And then I want to perform the AWV medical encounter and document it in the EMR. And I need to complete the appropriate and effective coding and billing. And you have this link over here to learn more, but in a quick summary of how you can implement that is helpful. Now, I would also say that I've seen incentives that are tied to this. So some practices would encourage the MAs to say, if you are able to complete about 80%, 10%, you get a bonus. So you can see this MAs pulling the patient out of the car, say, hey, come back, and there goes my bonus. So, and then the more important thing is it done well? So when the claim is denied, the disincentive is that you have to pay back the practice for making them lose money because you did not do the AWV well. So you have zero problem with that. So it's comprehensively done. They've come up with very innovative ways to do it. I'll start by reviewing the previous AWV so that they can have a quick knowledge, and when they're prepping the patient, just go through it quickly and say, hey, just trying to check through what has changed and things like that. And I'll also say that the information gathered in AWV, if it's well captured in your EMR, is really a data source for so much more, for the nurse doing the assessment, for the care management, for the CHW, doing an assessment for intervention planning, for social needs. So again, if you coordinate it that way, the patient doesn't feel like you just asked me that question last week. Well, that was the MA. Well, I thought you guys worked together. So again, before you go out to reach out to a patient to ask them questions, ask yourself as a care team member, is this redundant? Could I have gotten this information elsewhere? It's different if you ask me, can you verify, versus just asking me the question as if you don't even know. Okay. So breakout, I've already asked the question. So is this configured in your EMR, the AWV questionnaire? Or is it handwritten? I see one nod over there. It's not? So what EMR do you use? Allscripts. We need to talk to them.
We use a question and then we do a personalized plan of care. And I got audited on Medicare a couple of years ago from the AWV, and the plan of care was not personalized enough.
So, but the plan of care, you get to choose that, right? You get the nurse get to.
It's personalized enough to say that you need to take a shot and you don't. So I don't know how much more personalized it would be.
So the good part is that we have an example. So hopefully we can help you improve in that department.
It's kind of silly. The other thing I take offense to is that in primary care, a chiropractor could do these annual wellness. It's totally not connected. It's cold call, they do it. And, we really have to do a campaign to encourage patients not to do free, because they get told and it's free care. And then they get billed for it, and you can't.
And you can't.
And there's no connection. This chiropractor in Illinois,
yeah, so they've presented that problem to CMS, but as you know, it will take a long time for them to kind of fix that. But to your point, the only thing you can do is to get ahead of it and campaign for it. Yeah, I mean, the only thing I can think about, and this is just me thinking, out of the box, is if your patient does see the chiropractor, that's another extension of the care team. You can have a care collaborative with that chiropractor if it have a high volume. In Illinois. Oh, it's across state lines. Wow. Okay, great. All right, but I'll share that feedback again with the state and CMS that this is still an ongoing issue, so you need to, fast track fixing that problem. Yes, ma'am.
So when we're billing for this, we need the G code and the C code?
Yeah, for both the initial and the follow-up.
But in a way, they don't even care how much of a physical you do on the patient?
It's not really a physical. It's kind of more encompassing, but that's why you need the physician's, review, because
I just thought the Z code was the actual physical exam.
it is, But what I'm trying to say is that because you can have your MA support you with doing all that, but you review by reviewing, and that's why it has to be completed when the patient comes in to see you. You cannot just send a questionnaire over the patient portal and then call it a day. So that's why that piece has to be done when the patient shows up for an office visit. So it gives you that opportunity to say, yes, I have completed requirements for the Z code by reviewing. Yeah, go ahead.
But it does have to have the Z code. It can't be like a 99214 plus the G.
Yes, you can.
You can also do
What
that.
I'm asking.
You can also do that. Go
Do
ahead.
it that way.
Yeah.
We do it with our comprehensive.
And it still counts
Modifier,
as an
Yeah.
annual visit, annual wellness visit.
you have to do the G code
Yes.
with your. Contributions are actually at like almost 90+% of our active Medicare patients. Because we've been doing annual wellness for 6 years, 7 years. I can show you.
Does that work for you? You want us to, we can circle back. She's in her world. I'll let her come back. So I'm glad that you said you meet up to 95% of your panel, because how do you track that? And at least you can just say we hit the 95%. So the question is, how many of us here in our practices know the percentage of our patients that we complete AWBs for? Because if you stay on top of it, that's the only way that you can make sure that you're getting at least your attribution list completed, and of course, more importantly, that you are getting to take care of your patients and assessing them. Now, by show of hands, how many of you currently administer the behavioral health screening? Yeah. So I will do this poll now, but I'm assuming, because when we do it and have people type in what they use, the PHQ 2 and 9 is the biggest one we see, and then you see SBRID and stuff. There is a I think it's a 9-video series, learning series done by Dr. Haft at the state. It's still online, and we can send you the link as well. And he takes the time to go detail by detail by detail by detail. It is a long process to establish behavioral health integration in practices, but at least it's a slow journey we are all on together. So don't feel that you have to get it all completed or all accomplished in program year 1, but please use the, people already, all right. Screening tools. What tools do you use? I was hoping to see PHQ 2.9 and so on and so forth. So I'm going to pretend I did not see that slide. Okay, so as we said, you have behavioral health. So we'll just go over really briefly behavioral health integration tools. SBRID, for how many of you have met with Mosaic from the state? Just you? Oh, everyone? Okay, good. So please leverage it as a free resource that's provided to you courtesy of the state. So please leverage if you can. The impact model. Also, we're going to watch a behavioral health handoff video. So you see that if you have a behavioral health specialist co-located with the primary care physician, how easy that handoff can be. And we recommend you reviewing the behavioral health integration mini-series on the PCP, MDH MD-PCP website. I believe it should also be on Connect as well, but either one that's faster for you. So let's go ahead and watch this video so you see how seamless that handoff can be, again, if you're co-located.
Dr. Kessler, thanks for joining us. This is Mrs. Stroder.
Hello,
Hi,
Mrs.
nice to
Stroder.
meet
How
you.
you doing? I'm Roger.
Hi.
So we've been working on managing her blood pressure. I've had to increase her blood pressure medicine doses over the last few years without really good effect. And I'm worried about the trend that I'm seeing. And I'm wondering what thoughts you might have. We did finish the behavioral health screen today, and some of her answers show some concern regarding mood, and alcohol use.
Oh, and have you talked about whether there's any relationship between the mood, alcohol use, and hypertension at all?
I have alluded to it and thought that perhaps you could help us more with that.
So I have a little bit of a strange job.
Okay.
I'm a psychologist that works in the practice, and I don't really do very much regular psychology. The work that I do is working with folks who have medical issues that mood or substances or alcohol or stress are influencing either the medical problem or sometimes people's ability to do the things that would make the medical problem better. So Dr. Stafford and I work together a lot. And so when he called me in to talk with you, it's something that we do pretty regularly. And so do you think that there may be any relationship between possible stress and drinking, and maybe that works its way around to how come the hypertension has been a little difficult to control?
I have been under a lot of stress lately.
I see. And do you think you're doing a good job managing the stress?
Trying.
Uh-huh. So sometimes it's helpful as part of medical treatment to spend some time with me, usually only a few visits, and to try to look at some of the issues related to stress and some of the issues related to alcohol and see if we might be able to manage them any more effectively. And I'd be happy to do that if you were interested.
Can try that.
Great. Then why don't we go on down the hall and make an appointment when you can come in to see me?
Okay.
Okay.
We can try
At
to
your
do that.
convenience. Great. Well, thank you very much. And thank you, Dr. Stafford, for asking me to come in.
You're welcome. Thanks for being here.
So as you can see here, the thing I liked about his approach was the way he used motivational interviewing techniques. He was trying to suggest to her what he thinks the problem is. He understood the stigma of saying, I'm an alcoholic, and that's how I deal with my stress, to say, do you think this might be encroaching into your medical needs? And try to make it look like a medical problem and not a mental, illness-related problem, behavioral health problem. And then he offered her up, a brief intervention, maybe just 3 visits, right? And then, maybe from there. So this is something we should think about. Now, if you're not co-located with a behavioral health specialist, you could try video visits. So the provider, the PCP could have been there, and he could have just initiated, I don't want to say Dr. Phil's doctor on demand, but but something similar where I can in real time reach out to a psychologist and say, hey, I have this patient, can you talk? I think in that moment, what the patient is seeing is that my medical and mental health kind of are one and the same, so I don't have to feel the stigma of it.
In your experience, does it have to be, or is everyone using a psychologist, or do you have like social worker? Do you have different levels of behavioral health that you're tapping into? Different levels. So
for the program, you have to choose one of 2 options. It's either to have a behavioral health care manager, or you have a behavioral health specialist like a psychologist. What I've seen predominantly are behavioral health care managers. And if you did watch the BHI mini-series, it asks, so what qualifies a care manager to be a behavioral health care manager? So it could just be one of the MAs in your practice that you train up in how to ask questions, elicit questions from the patient, and how to make the right referrals. So that's, again, this year is just about identifying and initiating. So I think over time it will become more intense versus who was it escalated to and what did they do thereafter. But right now they do know the struggle with resources and having a plan for it. So the fact that you're even doing something is a good place to start. Because if you say, well, we want you to choose option 1, I believe it is, and make sure you have a behavioral health specialist co-located. Well, what if they're not around? So for that reason, they have to make sure on this end that they're shoring up resources from a statewide level before they make that demand of the practices. And for those of you who do not already know, we do have one organization that did qualify as a CTO, but right now they function more or less as a behavioral health support for CTOs called Mindula. And that's really their expertise. So if you refer your patients to Mindula, they actually take in the patient and they provide care coordination, they refer the patient to psychologists, psychiatrists, anything behavioral health needs. And the good part is that it is at no cost to the practice because they can bill for that under COCM. Now, let me say this because some practices shun them when they reached out to them, because if you are in MDPCP, you cannot bill for CCM, and COCM is different. So it's collaborative care management, different from chronic care management. So there's a difference in the different billing codes. So if you ever have that, I don't know, at one point they were at capacity, so they were not able to take in more practices to support them. So, but if the demand is there, they already have a model, they've been doing it for years. I don't see them not expanding that. So if that's information you want, you can circle back with myself, Angelica, and we can get you that information. But I think they.
Does that cover all of it?
Yes. Yep. All you have to do is sign the necessary consent for them to have access to your EMR and your patients, and then they do everything. But you have to send in the billing though. So, but everything else is they'll figure it out for you. And they are. I know also some practices thought it was a fraud, but they've been vetted and reviewed. Their process reviewed by the state, not endorsing them. But yeah, it is legit. It is a good support. So most of the practices I know that work with Ashley CTO use Mindula.
What's the name of it again?
Mind Your Mind Doula, OULA. So they're vendors to the CTO, and through that they're able to provide behavioral health support to practices. Yep. All right. So PDSA and behavioral health screening, the question is, how can we ensure universal behavioral health screening for all patients? Test of change, increase the number of screenings performed. The plan, develop a work plan, train up the MA staff. Some of you had Mosaic come out to perform behavioral health screenings. Document the screening results in EMR for the care team to access. The MA performs it and documents, study the percentage of impaneled patients who received an annual behavioral health screening, the percentage of the behavioral health screenings that performed that were positive, because you need to know that the next step was done, they were referred to or treatment was initiated. So the act is universal behavioral health screening will be performed by the MA staff during patient visits. This, when it's due, this will give providers enough information and time to perform either a brief intervention and or refer for treatment. So again, this is a short PDSA that can be done and you can check the box. So step E, post-consult with Ms. Alexa, patient education, prescription, review, referral, and if you need to call it in, referrals, consults, lab work, follow-up, and prepare room for the next patient. Ms. Alexa's experience here is that she's happy with being able to discuss all her concerns with the physician or the provider and have a care coordinator help her with understanding next steps. So here at checkout, scheduled appointments, you want to make sure that the front desk staff has some script that they go by, because you want to make sure that the same communication for the most part is given to all patients, either at time of check-in and check-out. So again, think about that. You want to reinforce and confirm that the patient understands and have knowledge of their visit, coordinating referrals, soliciting questions, and then closing the communication loop. So a recap for phase 2, we use our test patient Ms. Alexa to have a practical conversation about activities that occur during the patient office visit, reviewed requirements on medication reconciliation and medication management, ECQMs, using data to improve care delivery and behavioral health screening, reviewed how you perform your AWB, who does it, how you bill for it, and then care team warm handoffs and the patient's care delivery experience. So please take a moment for the post survey for questions 13 through 17. And if you see, for the post survey, not sure if we call this out for you, but it's a call to action. So hopefully that you feel empowered enough now that you know more to do more, right?